So left main disease and choosing CABG, I have no disclosures. So we all have seen the updated recommendations from ACC, AHA, and SCI about left main disease. And I think that this really oversimplifies things as we've discussed here in this session and earlier today. So they have left main disease, are they a suitable CABG candidate? And the decision in terms of that is really much more complicated. So starting with a case, this is a 68-year-old gentleman. He is retired, very active, medical history of reflux, some dyslipidemia, on medical therapy, obstructive sleep apnea, really no surgical history. He's on goal-directed medical therapy, still has some dyslipidemia, and normal labs, hemoglobin A1C is 5.5. He was seen in an outpatient cardiology clinic, and they moved ahead with a coronary calcium scoring scan. So he had significant coronary calcium over 2100, and then proceeded with left heart cath. So his right coronary, small, non-dominant. His left side was dominant, mild left main disease, however, diffuse and some proximal disease of the LAD, osteal ramus disease, and then osteal disease of the circumflex. So when we're looking at this, I think it's important, of course, to know what side is dominant, but then also when I'm looking at this, I'm trying to figure out which targets we're going to go after. So as discussed earlier today, the targets are really important in terms of both stratifying patients for therapy and then also planning our operation. This is another view of his LAD, some diffuse disease, but definitely there's targets there. He did have an LV-gram, normal left ventricular function. He also had an echocardiogram that I won't show here, but no significant valve disease. So here we have a 68-year-old gentleman, left main equivalent, stable angina, low-risk patient, no diabetes. Think that this one for surgeons is relatively straightforward and non-controversial from our perspective. That might not be the same if I polled the audience, but he was discussed in the heart team, and we went ahead with bypass grafting and using a multi-arterial strategy. I think as the surgical community is more conscientious of multi-arterial grafting, this patient is a great candidate for this. He's young, no diabetes, and has sufficient proximal disease that he can that we can do nice arterial grafts. So we did an in situ lima to the LAD, in situ right IMA to his ramus. We did do a saphenous vein graft to the OM, and then he got sternal plating and did well and was discharged on day 5. So just a little bit about multi-arterial grafting. I think this is something that we're getting more and more information on as we have late follow-up in these patients, but there is a late mortality benefit in patients who have multi-arterial grafting compared to Lima LAD and vein grafts. This graft just shows the utilization of BEMAs in the black lines, and then radial utilization in the United States. And as you can see by the scale, this is a scale of 10%. So really our BEMA utilization and radial utilization at the national level, so this was from our STS database, is still pretty low. There's multiple reasons for that, but I think that this is something that the surgical community is really trying to pay more attention to and utilize multi-arterial grafting when we have the opportunity to operate on these patients. A next case, 73-year-old gentleman, he was admitted with unstable angina. He had a medical history significant for right carotid arterial occlusion and a stroke about 10 years prior. He did have some residual deficits, was a pretty functional gentleman. He had type 2 diabetes, no significant surgical history. He was on goal-directed medical care, creatinine upper limits of normal, and his hemoglobin A1C was 7%. It's not quite as ideal of a surgical candidate. I think whenever there's a history of stroke and particularly a carotid occlusion, that does make us a little nervous. This was his left heart cath, so he had 90 to 95% left main disease, 80 to 90% disease of his LAD. He had occlusion of his circumflex that filled both from the right and the left side. It's another shot of his left main. And then here's his right-sided injection that does show collateral filling of the OMs. I think that it's hard to sometimes estimate what type of bypass grafts or targets we'll have on this side, but we're pretty confident that we would be able to find something to bypass on this side. He had an echocardiogram, EF reduced at 45% with some lateral wall hypokinesis. His right side was normal size and function and no real significant valve disease. So this gentleman, a 73-year-old with left main and right carotid occlusion. We decided to proceed with CABG in this patient as well due to the complexity of the left main and then also the occlusion of his circumflex. He got a Lima to LAD, a vein graft to OMs and PDA. And the biggest discussion in this patient was what to do or how to fully evaluate his left carotid. So I think these patients where all of the cerebral blood flow is coming from the left side, of course, makes us nervous. So we consulted with vascular surgery, and there was no significant disease in the left carotid. So we felt it was safe to go ahead with bypass. And he did not have significant calcification of his ascending aorta, so we were able to go on pump and cross clamp. So summary, well, these are our guidelines. I think that there's a lot more, of course, that goes into the decision-making in these patients. What's their ejection fraction? How is their disease pattern, including conduits available, diabetes, longevity opportunities, when we can do multi-arterial grafting. I think as surgeons, we have the responsibility to do that. And then, of course, there's a multitude of patient factors that go into play that really cannot be encompassed in the guidelines. Thank you.
Thank you, Kimberly.